My name is Stephen Abrams. Everybody calls me Buz. I'm an emergency physician. I work in the Bronx. So let me give you a rough idea of what a day in my life in the emergency department is. My day starts realizing that I have to go and that there's a certain amount of risk I'm going to face. I'm reviewing everything that I am going to do in terms of sequencing when I get to the hospital, when I park the car, what I'm wearing when I touch the hospital doors to go in, go to my locker. I don't wear this pullover type shirt in the hospital. I ordered what's called a scrub jacket, which is button-down snaps. Many nursing supply places carry these button-down things because I didn't want to pull anything over my head. I wanted to just take it off when I'm finished and drop it. I may require a gown, protective gown, full PPE. I may require the shield or actually goggles, a hair bonnet. I wear the N95 from the moment I set foot in the ED until I leave. I do not eat or drink for my entire shift. After 45 minutes in an N45, your mouth feels like it's on fire. We have an enormous department, just in terms of square footage. And we had to find even more space within that vast space to store even more supplies and take care of more patients, which necessarily meant people are being treated in chairs, some in stretchers, the sickest, of course, in the resuscitation areas. We still have to take care of the patients who are non-COVID. So, and I have very vast experience, and intubating is not really all that difficult after all these years. And my colleagues with whom I work, many of whom are attendings and younger than I, have, the only word I can say is they've pushed me out of the way. They brought me to less COVID-intensive areas of the ED. They have accepted more risk so that I could have less. And this was spontaneous on their part. The honor and esteem with which they've given me that benefit is exceeded only by the impossibility I have of ever repaying their generosity. Now, that being said, I am probably a total pain in the neck to them because I constantly correcting their glove technique and their gown technique. I am fairly sure that the initial wave of physicians in the ED who got sick from incredibly sick patients who we had underestimated based on knowledge at the time. And now it's based on carelessness, touching themselves, futzing with the mask. People do automatically, talking on their phones all the time. So I think we're seeing now some carelessness. So that's my contribution to the general environment. But the patients still come in. We have to take care of them. We try to keep the ones who are non-COVID, sprained ankle, chest pain, whatever, away from the sicker patients. And then what we call patients under investigation, we're not quite sure. So our daily routine is basically trying to segregate the obviously sick from those who we think are not sick, and among those who we think are not sick, there are plenty who have COVID, maybe 50% on some days. The sickest of the sick is something that is indescribable. Because in these patients, this bug goes right for the lungs. It's severe acute respiratory syndrome, SARS, right? Goes right for the lungs. Now, if they've stayed home, they may have had low oxygen for several days. And then what happens? The cells in the kidney start to shred. The cells in the liver start to shred. The cells in the heart, which need a lot of oxygen, start to shred. The cells that regulate blood clotting and coagulation start to become dysfunctional. The mental status becomes more and more loopy. And they come in with oxygen levels that are outside the range of calibration on some of our most advanced devices. Some people can't even turn over without getting short of breath. They are the sickest patients I've ever seen, for whom we can do absolutely nothing definitive. We have no medication to offer them that will kill the virus. We can offer them life support, intubation if they need it, high flow oxygen, special helmets. We've learned a huge amount in 6 weeks on the best way to pull these people back from the brink, some of whom we cannot, and that's very distressing. And some of them look great and then crash unexplainedly and are dead in hours. So that's over in the resuscitation area. We still have our cardiologists who come running down in full gear to see people who are having heart attacks. Got to treat them. Our neurologists running down in full gear to treat people who have strokes because they need to be treated. So we see our usual spectrum of illness, which tends to be dominated by COVID in general because people have been staying away. People who should be coming are staying away. They got the word out to, we have an urban impoverished community, predominantly Spanish speaking. They got the word out in all the Spanish media to be judicious about when you come to the hospital. People are just not coming. I think they're starting to filter back in now. So the bottom line is, what is my day like? I spend it all day in a mask and a gown. My voice is muffled. We can't even understand each other speaking when we're discussing cases. I don't go to the break room. I don't go to the lounge. I take care of what I usually take care of. I teach as I usually would teach. I instruct as I usually would instruct. And as I encounter patients with COVID, we treat them too. When I go home, the last 20 minutes, when I know it's a 12-hour shift, the last 20 minutes, it seemed like it take 4 hours. I doff all my gear in a certain way, using hand hygiene. I put my clothes in a bag. I go out using precautions through the doorways and touching things. We have a huge amount of patients in this hospital. I get to my car. I have a sandwich that my wife insists on making every morning. I have ice cold water. She's put in, when you were a kid and you went on a field trip, there was those little ice things. That's in there, and it's all neatly done with a napkin and a plastic fork. It's the most delicious water and the most delicious sandwich I can ever remember having. Then I go home, play with the dog, drop my stuff in the laundry, do laundry immediately, take a shower. So a 12-hour shift is actually, with a donning and doffing of gear and sequencing and being ultra careful, a 12-hour shift is really a 15, 16-hour day. And it gets a little wearing if you have to do them day after day after day, 2, 3 in a row. But I really should not complain. I have colleagues, very skilled, very talented, very smart physicians who've been working 4 or 5 days in a row, have been working only critical. They say in the Civil War, the soldiers would retreat going backwards because they didn't want their families to know that they were shot in the back and were cowards. And I think, I'll tell you, there are no cowards in my department. No one has ever shied away from a patient. People always want to know if I'm scared, and when they're thanking me for all I do and being frontline, they're still backing up a foot or two because they think I might be carrying some toxic illness. And am I scared? And yes, I am sometimes. I'm nervous and anxious and tense. This disease has forced us all to think about mortality. You see people who should not be taken so terribly, and you think, could this happen to me? So I will tell you that at my medical center, I actually admitted the first COVID patient. And the sequence of events was like this. I came on to the critical side following a very smart new attending. I think she's in her second year running the show. And this attending tested this patient for coronavirus. Now, at that time, and again, we're talking 6-7 weeks ago, it could have been prehistoric times. At that time, the recommendation was you would test people only if they'd been to China, only if they had fever, cough, and on X-ray or CAT scan, pneumonia on both sides, only if they'd had close contact with a COVID patient. But something about the story she didn't like, so she tested. And again, back in the prehistoric time, the test took hours and hours and hours and hours and hours and was often sent out to get. So I come on with all my experience, and she tells me this patient there in the negative pressure room is, I'm ruling him out for coronavirus. The patient, because of the testing delays, because testing was in its infancy, had been in the ED for 30 hours. And she told me, he has a pneumonia on one side. He's been sick for a couple of weeks. He was up at a rock concert and came home. He was just feeling crummy. And I'm looking at her thinking, she's been here all day. I'm not going to give her a hard time. But this clearly is not coronavirus. So I go in to see him. And because it's my first contact with him in the negative pressure room, and I do not poo-poo anything a fellow attending tells me, I gowned up, went in and spoke to him. How you doing? I said, doing fine. I was coming back down from the rock concert. I just wasn't feeling well. I can't believe I have pneumonia. They say I have coronavirus. And I say to him, I don't think you do. Doesn't sound like the profile of these patients. Chatting with him. His oxygen was a little low. It was 93. But every time I walked by his room, and I was on a night shift that time, he's waving out the window, and I'm waving to him. And then I opened up a couple times. I think I'm going to let you. We're trying to see if we can get you home, sleep in your own bed. Just want to get some more vital signs. The oxygen just wouldn't come up. It was pegged at 93. He was eating, had an empty tray. Now he's sleeping again. I think, the poor guy, he's been on 2 inches of foam for 30 hours. I'm just going to bring him in, put him in a real bed, and give him some oxygen, give some antibiotics. This fits the profile of bacterial pneumonia, and we'll see. He was dead 5 hours later. Now, I didn't know that because my shift had ended. I come back 5 days later, and one of the PAs with whom I'd worked that night comes racing over to tell me, said, you remember that patient we saw the other night? I said, yeah. He said, he died. I said, of what? He said, coronavirus. And now I'm thinking, I'm in the room with the guy. I gowned up properly only once. I could have been exposed. I'm trying to remember if I had been, 3-4 feet away from him. And then, as just about any doctor in America would do, within 5 minutes, I've decided I had a sore throat, I had a headache, I'm not smelling things. My life is passing before my eyes. And, I was rocked. And I figured now I had to get through the next 5 days for a total of 10 days post-exposure to see if I had any symptoms. I was taking my temperature 10 times an hour on these little dots. And some of the dots were defective. And I'm walking around feeling myself. And I wasn't sleeping. the person you see in front of you right now, I'm probably 15 pounds lighter than I was 6 weeks ago. So yeah, that particular episode was scary, and it made me realize that the spectrum of illness with coronavirus is very broad, and that the guidance we had was utterly wrong. We've now realized that the spectrum of illness is not only broad, but has a real tail of insignificance. People don't even know they have it. And that's coming from testing. So that's one of the reasons why I decided that I had to do something to help people manage the context in which they get this information. Because they're not specialists. We're asking these people to be their own doctors, to take care of their own family members, to gown up, now to make their own masks, to go in public in a certain way. Asymptomatic infection makes you regard your neighbor as your enemy. We have to give people tools to function without trembling. I am in there and I'm aware of what I'm facing. And I'm not as scared. So this is a multi-dimensional public health issue. We have to be in our moments. I will take care of the people who need to be in the hospital. You will take care of yourselves and those at home with you. We'll help our neighbors. And we'll wait for our leaders to come up with the plans and the policies and the empathy and the compassion we need to get all of us through this. When we see a car race, they interview who came in first, second, third. Healthcare reporting, healthcare media is totally backwards, right? Because the way you keep someone's attention is to scare them to death. We don't see interviews with the winners. We don't have people come on every day and say, I had it. I felt really bad for a week, but then it went away. Or someone come on and say, I couldn't even believe I had it. I had just a headache and my ears were ringing. And they tested me, I was positive. I couldn't believe it. That's not what you see. You see the 4 orphans whose 36-year-old mother died unexpectedly of it. You see the family that's wiped out. You see someone who required intubation for a month. Because in healthcare reporting, the best way to keep your viewers is to scare them to death. You have to understand that these numbers you see every day, the mortality rates, are based on hospital reporting. It's an entirely different kind of patient than someone who's sent home, someone who gets it in the community, someone who gets an infection they completely overlook as being insignificant, and others whose numbers and whose extent we have no idea because we're just starting to test. But it appears that the pertinent points of this bug is that the vast majority of people who get it, an extraordinary majority of people who get it, are going to do very well. The problem is, obviously, if 10 million people are infected and 1% require the hospital, that will take down every hospital bed in the country. We've learned that patients can come in as non-COVID and turn out to be COVID positive. I can tell you of a patient, a very nice 79-year-old lady, who was sent to the hospital by ambulance because she had a fever and seemed confused. When she got to me, her oxygen was 100%. Her respiratory rate was not labored, was normal. Tested her anyway to see if she had it. It's better to know. She had it. Okay, the most bland presentation. Half hour later, after fluid and Tylenol, she looked great. She was keeping food down, no cough, oxygen still 100. She went home, she did fine. Among the most common comorbidities in a nation of 350 million are obesity, hypertension, diabetes, and I believe either heart failure or some sort of respiratory issues. And we have an aging population. And we have a sedentary population because we have a lot of people who have to work every day and they can't go mountain biking or work out in a gym. And if you're obese and you're not working out, then that gets worse and makes the diabetes worse. So there's a lot of things interrelated. Obesity, if you're trying to breathe, if you have a respiratory virus and your chest weighs 200 pounds, you're going to have a problem. That's all there is to it. But the burden of concurrent illness that made people more vulnerable to this virus really speaks to the need for greater access to health care and improvements in people's health profile. There's tremendous emphasis on a medication because we can't do anything. We can't do anything. So if we had a medication, that would be great. But the medication has to be tested rigorously. This was a disaster with the hydroxychloroquine. It was never tested against a placebo group that got nothing. There was no science. We have to test things in a way that we see the people who got it, and we see the people who didn't get it, and we make realistic comparisons. We don't know if this bug is going to be part of the human condition and appear yearly like influenza and require yearly strategies for control. If enough people have had it in a locale and it's passed through all these human hosts, are those who have not had it and do not have antibodies, are they negative? Are they safe by what's called herd immunity? We do not know. What we do know is that a vaccination requires time. In the early days of HIV, when they're looking for treatments, it became apparent that if you just gave one effective medication, the chance of the virus mutating and becoming resistant was extremely high. It was almost a certainty. If you gave two medications, the chance of it mutating was much less. Or actually having a mutation allowed it to survive was much less. But if you gave three medications, the chance of that bug becoming a resistant variant was like 20 million to 1. Similarly, with this virus, which things are extremely difficult to treat, the treatment strategy is probably going to be multiple drugs. I wish I could tell when these drugs would be available. I do know that very smart, very capable, very committed researchers across the industrial West, Europe, here, and I assume in China too, are working around the clock to come up with a medication. That clock is going to tick slowly. That's all there is to it. These things are going to take time. In the meantime, we have to deal with, all these other consequences of this health emergency, the unemployment, the hunger, poor access to meds, and avoidance of advanced care when you really need it. The immunity will take care of itself. We have been dragged into the era of telemedicine. There's no question that this pandemic has pulled us into the new millennium. The contribution of telemedicine has been enormous, and I think some of the interfaces are still clunky, and the bandwidth is not always great, and different hospitals are on different systems and different doctors' offices, but this is not going away. It's efficient. It's probably economical. It addresses the fact that you have to take care of patients when the clinics are closed, the doctor's office is closed, the doctors may not have PPE, right? Someone wants to show you how a rash looks or if a wound has gotten infected. So if you have resources at home that support that kind of electronic interface, we're going to see more and more and more of telemedicine. And we could not have managed the patients that we had without our electronic health record. Even if you require hospitalization, you're probably going to be okay. a small group of people are going to have a very unhappy, unsatisfactory outcome. As we do more and more antibody testing, and we see that people have been exposed in some way and made antibodies, we don't know what that dose was that they exposed. Many of them can't even remember what happened to them. But if that number is so big, then the death rate really, really is small. Now we're told, as part of our ongoing safety efforts, you should wear a mask. And you can put on a mask the correct way and take it off the wrong way and have reaped no protective benefits. Okay, my friends, let's discuss putting the gloves on. That's really not all that difficult. We note again together that a little bit of trampoline stuff here, right? And if the front of these became hot with contamination, taking these off the wrong way, bing, okay? Could spread back on you, could snap onto your face, you don't know. So you have to take them off a certain way, which is not at all difficult. With one hand, you pick up the glove, take it off. Curl it up, okay? The other hand, you get under the glove and pull it off this way. Okay? We drop it and we wash our hands. Now, my friends, I want to show you something. If you're wearing just customary comfort gloves, they'll give you some protection, no question about it. The virus gets tangled up in the fibers, doesn't necessarily migrate into your body. But you have to take this glove off kind of the same way. Okay? So let's review. You want a glove that's not like constrictingly tight around the wrist, right? So you pull it, glove to glove. Okay? And then this one comes out. A little more snug. But again, we've done it safely. You drop it in the receptacle. If you have the woolen gloves, which are a little looser, that's fine. I wouldn't wear leather driving gloves, something like that. But if you have a comfortable pair of loose-fitting gloves, you get on and off easily. We've all seen these. These are doggy waste bags. They're relatively ubiquitous. They're impervious. And you can put them on. And you could tell if an avocado is ripe or something with this. But what you want to do is you want to twist it a bit and tuck it. Take a bit of practice, but you can do it. And then same thing. Same exact thing when you take it off. Assume the front of the glove is hot. Touch the glove part. Curl it up. Then these things are a piece of cake to roll into one another. Okay? These are boxing gloves. They have no role in the community or in the hospital. Okay, so first let's look at this surgical mask. Let's note a couple things together. First, it's a fan fold or an accordion fold, so it requires manipulation. This is a version of the famed N95. I am not going to put this on in this setting. This belongs in a hospital. I will use this myself on my next shift. These are worth their weight in gold. They filter out 95% of particles below a certain size and keep us safe. They have no role in the supermarket, in the post office, or at the gas station. Now, we also see people walking around in the communities with something similar to this. We use things like this in the hospital when we are over people who are breathing out tons of viral particles while we're trying to fix their airway and get their oxygen up. And if you have one of these that you can give to a physician of your acquaintance, that would be a good thing. If, for some reason, there's a nuclear spill in the dairy section, okay, you can go get eggs from me in this. Okay, so this scenario is pretty common. You're wearing your gloves and you're wearing a mask. If the gloves are hot and you go up here to take the mask off first, you can contaminate the mask and potentially inhale particles. The rule, which is very simple, these are your collarbones, right, the clavicles. Anytime your hands are coming above your clavicles, they should be ungloved. The gloves come off first. All right, you see how we're doing it? Again, we're touching only the inside of the glove now. We drop it. We wash our hands. Here we go, above the clavicle. The mask, you don't want to do this. You don't want to do this. You want to take it off away from your body, crumple it up. We note together that the front of this mask could be hot and I've touched it. We drop it down. We wash our hands. So hand hygiene is the key thing at every step. Take your gloves off, wash your hands. Take your mask off, wash your hands. As many of you do when you go outside, I'm wearing now these eye shields, these workshop shields. Trying with an abundance of caution to prevent any viral particles contacting the eye. Your airway trumps everything. The mask is the last thing you take off. Because if you're contaminated high up on the goggle, you could have particles land in front of your mouth if the mask is off. The first thing that will come off will be the gloves. I perform hand hygiene. I would reach up now, ungloved hands, take off the hat, drop it to the receptacle. Hand hygiene. Just a drop of sanitizer, all you need really. Now I take off the goggles, hand hygiene. And finally, the last thing that comes off is the mask. So again, just a couple of general observations. You see a lot of very bad mask technique. You see people constantly futzing with it, make sure it fits right. You see people bring it down below their nose, drop it to their chin, okay, let it dangle from one ear. You don't want to do that. And you are no more protected from that poor behavior if you're wearing gloves. Here is a medication, a safe medication that will go unnamed. It comes out as an aerosol, okay? It's the same way a human breath comes out as an aerosol of viral particles, all right? And I'm going to just... The front of my mask has gone hot. And now I am not paying attention, and I touch my mask. Should I buy some avocados tonight, or should I buy lamb chops? That's not satisfactory. You just must have complete situational awareness of where your hands are. You must not think that gloves are inviolate protection. You should not be afraid to touch things that have been contaminated because you're going to wash your hands after every movement. Again, you don't need a ton of alcohol-based sanitizer. It's very precious. This virus is extremely susceptible to alcohol, so it just like shreds and it's gone. Remember, your airway trumps everything. If you're wearing a mask, know how to take it off safely. If you're wearing gloves and a mask, this is not a good idea. Anytime you cover above your collarbone with gloves on, those gloves come off. If you're wearing other gear, the last thing you remove is your mask because the airway trumps everything. And after every interaction with a piece of gear, you perform hand hygiene. And you got to be careful, by the way, when you see these ads for masks and things that are plentiful online now, do not buy these things that look like a cowl, is it? The round thing you wear, put over your head, and you pull it down, and you pull it up. Because you take that off by how? Going over your head, crossing your mouth.